Well, good afternoon, everybody. I think we'll get started. Welcome to Neurology Grand Rounds. It's my pleasure to introduce Dr. Katie Pagulayan today. Katie is an assistant professor in psychiatry and behavioral sciences and a clinical neuropsychologist at the VA. Before I tell you a little bit about her background, I met Katie pretty early on in my tenure at VA Puget Sound. I'm really glad I did because I was able to get her a little interested in epilepsy, and pretty much all of the neuropsychological testing that I order goes through her group, and I really appreciate that. And she was working in the deployment health clinic, and we realized a lot of the people that she was seeing, young combat veterans with mild traumatic brain injury, severe mood disorder, PTSD. These were some of the same individuals that were being referred to seizure clinic and ended up having psychogenic non-epileptic seizures. So those crossing paths in terms of patient care led her to generate an interest in treatment of psychogenic non-epileptic seizures, and she's begun doing some cognitive behavioral therapy for our patients over at the VA. So thank you for that.
Yes.
So Katie got her BS in psychology at College of Holy Cross in Worcester, Massachusetts, and then did her PhD in psychology at the University of Cincinnati. After she completed that, she came to the University of Washington in 2003 and has been here since. She did her postdoc in rehab medicine here, and then took a position as initially acting assistant professor and now assistant professor. She'd been supported by several grants and awards, most recently a career development award through the VA to study the effects of mild traumatic brain injury. And so without further ado, I'll hand over to Katie. Thank you.
Thank you. Okay, I'm really happy to be here today. Can everyone hear me okay? Is that working? Okay. So as Dr. Ransom said, I am a neuropsychologist at the VA, and I've been there since around 2007. And just in terms of a little bit of background, when I first started there, I was working almost exclusively with veterans with a history of TBI, doing diagnostic evaluations and neuropsychological evaluations for them. And so it was through that work that I became aware of the types of symptoms that these veterans were presenting with, and that really led to the research that I'm doing right now to try to better understand what's contributing to these symptoms and ultimately to try to find some interventions that might help reduce some of these symptoms. So I'm going to start out by talking a little bit about blast-related mild traumatic brain injury, how it's different than civilian traumatic brain injury, and then go into the research that we are doing at the VA right now. So TBI is frequently called the signature injury of the wars in Iraq and Afghanistan. This is a quote dating back to 2005, which is relatively early in those conflicts. This is a reporter from USA Today, and he said a growing number of U.S. troops whose body armor helped them survive bomb and rocket attacks are suffering brain damage as a result of the blast. It's a type of injury that some military doctors say has become the signature wound of the Iraq War. And that phrase, signature injury or signature wound, is continued to be used very frequently even today. So even in times of peace, the military has higher rates of TBI than civilians. And that has a lot to do with the activities that they're engaged in on a day-to-day basis. So things like parachuting and combatives and things like that just increase their risk for traumatic brain injury. And then when we have times of war, like the Iraq and Afghanistan conflicts, that incidence increases even further. And these conflicts have been particularly interesting because so much attention has been paid over the past few years to the frequency of these injuries and trying to understand how they're impacting these veterans on a long-term basis. So just in terms of some statistics, over 2.5 million U.S. service members have been deployed to Iraq and Afghanistan. And nearly 800,000 of them have been deployed more than once. And in the veterans that we see, it's not uncommon for people to have been deployed 2, 3, 4, 5 times. So a lot of time spent in these combat zones. And the estimates vary a little bit, but roughly 20% of those veterans who've been deployed are estimated to have sustained at least one TBI. the vast majority of them are in the mild range. And they're or they're very predominantly caused by improvised explosive devices, or IEDs. The statistic here says that 88% of injuries treated in the combat zone were due to a blast injury. And on the side here, I just have an example. This is from 2004, 2005, but it just illustrates the intensity of the combat that some of these veterans were involved in during their deployment. So for this one Stryker brigade operating in Iraq over a 12-month period, they experienced over 3,000 enemy attacks, over 1,300 IEDs, 84 suicide vehicle-borne IEDs, which are very large explosions, vehicles filled with explosives and driven in to something to explode. And then more than 1,500 direct fire attacks and more than 600 indirect fire attacks. So as you can imagine, it's very intense combat that a lot of these veterans have experienced. The Department of Defense is tracking how many brain injuries are diagnosed in the military over time. And so this shows that the majority of the injuries that are diagnosed are in the mild range. That's the yellow line on top. And the numbers have increased over time. Starting around 2007, you can see that there is more of a jump in the numbers, and they've started to come back a little bit. Now, the conflicts have been going on for longer than that, but more attention started to be paid to the diagnosis of concussions and mild traumatic brain injury around that time. So it's very possible that earlier on in the conflicts there were higher rates of TBIs that just weren't diagnosed. And blast injuries can cause injury to the brain by several different mechanisms. So one primary mechanism is the blast itself. So that blast over pressurization, force, or wave can in and of itself injure the brain. But then you can also have secondary injury from flying debris, bomb fragments, things like that that can impact the brain. Or tertiary injuries from displacement. So if the force of the blast actually lifts someone up and throws them, and they hit their head on something as a result of that, you can sustain a traumatic brain injury that way as well. And you can have a combination of two of those or three of those. So a primary blast wave injures the brain, then you also have a secondary or tertiary injury as well. So this is a video of a blast that went off in 2007. It's a very large blast. I'm going to warn you ahead of time, but the reason that I like to show it is because it illustrates that blast wave and the size of some of these blasts that the veterans have experienced. So it's multiple frames. It's going to, if you look, you can see the cars moving to know that things are happening. And here comes the blast. And if you notice, the dirt right here changed colors in between. There it is before the blast. Here it is after the blast. And that's the blast wave coming. And then this just shows as the blast wave reaches the camera. And then just one more illustration of what these blasts are, and just to really get a sense of what some of our veterans have experienced. This is a vehicle that is frequently used in Iraq and Afghanistan. And this is a picture that was provided by one of the participants in our research study. He was in this vehicle when it ran over an IED. And it was estimated that it was about 80 pounds of ammonium nitrate that they went over. And there were 3 people in the vehicle. He was inside the vehicle in the passenger seat, and he and the driver both had a brief loss of consciousness. The third person was the gunner, which is the person up here, whose a large part of their body and their head is exposed, was more severely injured. And that's a really common thing that we hear, that if people were the gunners, and they obviously not only get the blast wave impact, but they often hit their heads on either part of the turret or going back down into the vehicle when the blast happens. So that's someone that can have a combined blast and blunt force injury. Okay, so obviously there's differences, not only in the nature of the injury itself, the blast wave versus blunt force, but just in terms of the environment that these injuries are sustained in. So this is just some of the similarities and differences, but in civilians, it's often a single mild concussion or mild TBI, excluding the sports repeated concussion side of things. Oftentimes in civilians, it's caused by motor vehicle accidents or assaults, and usually, if it's needed, there is immediate medical assistance available. And the literature is pretty strong that if you have a single mild concussion, that you have a resolution of your cognitive symptoms somewhere from within a couple of days up to the vast majority recover within 3 months. In the military, especially in the combat situation, multiple concussions are very common, especially as people have repeated deployments. As we mentioned, blasts are the most frequent cause of the injuries. Access to medical care is variable. So can you imagine if you're out on patrol and this happens in a far out area, you may just not have access to medical care immediately or potentially even for days, depending on where you're located. And these injuries can occur in the context of a very high alert level because these IEDs can go off at any time. So people are functioning under this very high alert level. Sleep while you're deployed is pretty variable. So people tend to have chronic sleep deprivation before the injury and potentially after the injury. Obviously, based on the video and the picture I saw, the chance of extreme psychological distress is high. And because of that, and because of the nature of the injuries, there's a lot of comorbid conditions. So all of those things factor in when we as clinicians and researchers are trying to understand what is going on in this population and how can we best help them. So given all that, there's been a lot of attention paid to the overlap in this population between TBI and PTSD. So Charles Hogue, back in 2008, said, a history of mild TBI in a combat environment, particularly when it's associated with a loss of consciousness, reflects exposure to a very intense traumatic event and threatens loss of life and significantly increases the risk of PTSD. So, based on the video and those pictures, you can understand why these are traumatic events that the veterans are experiencing. And in one study, they found that of veterans who screened positive for traumatic brain injury, 34% met or screened positive for PTSD. I'll say at the VA, clinically, the people who come to us for care, that rate of PTSD is much higher, and it's much higher in our research studies as well. So when the veterans come in for care, there is frequently a whole constellation of symptoms that people have at that time. So I've listed some of the common ones that I see in my clinic. So, veterans being referred because they have a history of possible mild traumatic brain injury, but when we go over their symptoms, they also endorse really poor sleep. Often they say they're sleeping 4 or less hours a night for months or years on end. They have chronic pain. Headaches are really common. Back pain is really common. Other musculoskeletal pain. There's cognitive difficulties, increased irritability, some anger discontrol. Substance abuse is present in some, and all of these things combine to have a significant impact on their personal life, conflict at home, impact on their ability to work, to go to school, all those things. And so, it's very common to see someone coming in with this whole constellation of symptoms that we're trying to figure out what is the best way to help them and to treat it. In 2009, Henry Liu described the common comorbidity of pain, PTSD, and post-concussive symptoms as the polytrauma clinical triad. It's so common to have those three together. And as you can see in this graph here, of the people who had a TBI with post-concussive symptoms for more than 3 months, which is the purple, 42% of them also had PTSD and chronic pain, and only 5% just had post-concussive symptoms. So then that leads to the question, so what are the differences between blast-related mild TBI and non-blast-related mild TBI? There's only been a handful of studies that have really tried to tease that out in terms of outcome, but what they've shown so far is that blast-related mild TBI is associated with more negative personality changes than veterans with non-blast-related mild TBI, and higher endorsement of post-concussive symptoms. Studies that have tried to determine if there's differences in neuropsychological outcomes have not found any differences to date. And then one study actually looked at the difference between non-blast mild TBI and then a group of people who had a blast TBI and a secondary blunt trauma, and also found no difference in their neuropsychological performance. So what we're trying to do at the Seattle VA is we have a large research study going on, some multidisciplinary group of individuals who are looking at different aspects of outcome after repeated blast-related mild traumatic brain injury. And for my particular research, we are trying to answer that question. So we know these veterans are having persistent symptoms for years post-injury. Most of the symptoms that they're having are not specific to mild TBI or diagnostic of mTBI. There's many factors that could be contributing, but what is the role of the blast waves and these mild TBIs in their current symptoms? And could the cognitive problems that they're experiencing be associated with any changes in brain functioning? So first I'm going to review some of the basic demographic characteristics of our sample. So we currently have 77 veterans with a history of repeated blast-related mild TBI. So I'm particularly interested in the impact of repeated blasts or repeated mild TBIs over time, and how that affects cognition and brain functioning. We also have 32 veterans who were in the military during the conflicts in Iraq and Afghanistan and were deployed but have no history of brain injury. So the two groups are comparable in terms of age and education and premorbid intelligence, and in terms of the racial breakdown of the groups. But the median number of blast exposures in the mild TBI group is 11. So we look at blast exposures two ways. So one of them is how many blast exposures did they have that were associated with symptoms. And so this could be an alteration of consciousness, a loss of consciousness, but it could also be something like a headache or a nausea or ringing in their ears, or something along those lines. And the range of exposures like that our veterans report is from 2 all the way up to more than 100. And the folks that are having more than 100 of these blast exposures, they tend to have roles in the military where part of their job is to go out and find unexploded IEDs or to detonate IEDs that have been found. And sometimes it doesn't go perfectly, so they might have some exposure from those as well. That being said, the median number of blast exposures with a loss of consciousness is 1 per person. So this is the mild traumatic brain injuries that they're experiencing are pretty mild in nature, but they're having a lot of them. The average time since injury is about 5 years. And then we look at the blast exposures that they report, and we see, well, do these meet criteria for blast-related mild traumatic brain injury? So do they meet ACRM criteria for traumatic brain injury? And the majority of the participants do meet criteria for 5 or more ACRM criteria, mild TBI. Okay, so the first thing we looked at is what are the psychiatric symptoms like in this population? And what we found is that, as expected, the veterans with a history of mild TBI have significantly higher depression symptoms, significantly higher PTSD symptoms, and 76% of them have PTSD as diagnosed by a structured clinical interview, compared to 16% of the deployed controls. And we have a subsample of individuals that we've followed over time. So one of our questions was, how consistent are these symptoms? So in this subset of 21 people, their first evaluation was done about 4 years post-injury. And their second evaluation was done about 3.5 years later. And these are the mean scores over time. So PCLM is measuring PTSD. PHQ-9 is a measure of depression. And NSI is the Neurobehavioral Symptom Inventory. And so these are cognitive post-concussive symptoms. And as you can see, these symptoms at a group level are very consistent over time. So these, at time 2, these are on average 7.5 years post-injury, and they're still very symptomatic on all of these scales. This slide just illustrates the variability in scores over time within the mild TBI group. So the lighter lines are the individual scores from time 1 to time 2. The darker line is the mean. So as you can see, there's variability. Some veterans are reporting more symptoms, which is a higher PCL score. Some are reporting lower symptoms. Some are staying the same over time. But it all averages into pretty much the same level of PTSD symptoms over that 3.5-year period. The next thing we were interested in is post-concussive symptoms. So how much or how symptomatic are these veterans in terms of post-concussive symptoms years post-injury? And this is the percentage of participants in each group who are endorsing moderate to very severe symptoms in each of these categories. So for example, 78% of the mild TBI group is reporting moderate to severe irritability all these years post-injury, compared to 23% of the controls. And then I highlighted the cognitive items on here too. So you can see 77% of the mild TBI group is endorsing a high level of forgetfulness, 69% is reporting a high level of concentration and attention problems, and 61% is endorsing slowed thinking. So again, these veterans are many years post-injury, and a very high percentage are still reporting significant, not only cognitive difficulties, but emotional difficulties, headaches, things like that. So then we wanted to know what is the relationship between those symptoms and the number of mild TBIs that they've sustained. So this graph illustrates that for the domains of the NSI, so that's that measure of post-concussive symptoms, and it can be grouped into affective symptoms, cognitive symptoms, and somatic symptoms. And for each of those domains, there is this dose-dependent relationship between the number of blast exposures or TBIs that they had. And for this graph, I did include our participants who have a single mild TBI, and then compared to those with 2 to 4 mild TBI and those with 5 or more traumatic brain injuries. And there is an increase in symptoms associated with a higher number of traumatic brain injuries. Okay, so then as a neuropsychologist, I wanted to see, well, how does all this translate to their performance on neuropsychological measures? So we know they've got a high level of psychiatric symptomatology. We know that they're reporting a lot of cognitive difficulties, and we know that these things have been there for a long time. So we gave them a battery of neuropsych tests, which is going to be showed on this slide as well as the next slide. This slide shows the memory and executive functioning problems or performance in the groups. And the interesting thing here is this line, the shaded area right here, is average range performance. So although the mTBI group is a little bit lower on all these measures than the control group, their performance is in the average range on all of them. The only test where there is a group difference in the memory domain is on a measure called the MIST, and this is a measure of prospective memory, which is basically the ability to remember. So remembering that you need to call someone in the future, or remembering that you need to schedule an appointment, those types of things. So the veterans are doing significantly worse on this test than the control group, but as you can see, it's still solidly in the average range. But interestingly, this is one of the domains where they do report a lot of problems. So this slide presents the results on measures of working memory and processing speed. So again, the results are pretty much the same. The performance tends to be in the average range. And on the majority of the tests, the mTBI group is a little bit lower than the control group, but it only reaches significance on one of the working memory tasks. And this is a task where they have to hold information in their memory while they're given a distractor task to do. And their performance is right at the low end of the average range, but still in the average range on this task. So this stands in contrast with their self-reported cognitive difficulties. So the brief A is a self-report measure, and it measures reported cognitive difficulties in a bunch of different aspects of executive functioning. And so what's interesting here is that the veterans with mild TBI are reporting more cognitive difficulties across the board on all these subscales. But the only one that reaches clinical significance is working memory difficulties. So a score of 65 or higher is suggestive of clinically significant symptoms. And in this population of veterans with repeated blast-related mild traumatic brain injury, that is the one score where on average they're reporting clinically significant working memory problems. All the other domains, they're reporting higher or more difficulties than the controls, but working memory is endorsed the highest, and it is the one that reaches clinical significance. Another way of looking at that is within each group, how many of the individuals are reporting symptoms that are at a clinically significant level. And so what this shows us is that about a third of the deployed controls are reporting working memory problems that are in the clinically significant range, whereas almost 70% of the participants in the mild TBI sample are. And some of the items on this questionnaire to just get a sense of what we mean by working memory is forgetting what I'm doing in the middle of things, trouble remembering things even for a few minutes, so like directions on how to get somewhere, what I went into the kitchen to get, that type of thing, forgetting instructions easily, and difficulty with multi-step tasks. So the combination of these things that veterans are reporting, a lot of day-to-day working memory problems, combined with some research that was coming out of our group that suggested that the cerebellum might be particularly vulnerable to blast exposures, led me to really focus my research on working memory. Because we know that working memory is associated with a neural network that involves the frontal, parietal, and cerebellar regions. So the research that was coming out of our larger research group had two findings that suggest that there is a cerebellar contribution, or the particular vulnerability of the cerebellum, I should say, to blast exposures. The first one is a study using FDG PET. And in this study, it was found that FDG PET hypometabolism was correlated with the number of blast exposures that someone had reported. And that was especially prominent in the cerebellum. And this was present even after controlling for a range of psychiatric symptoms. So PTSD, depression, substance abuse were all controlled for, and this correlation between number of blast exposures and hypometabolism in the cerebellum still remains significant. The second finding from our group of researchers was in mice. And in this study, they further investigated some of these cerebellar findings in a way that they were able to control for the potential impact of secondary or tertiary injuries. So this is purely a blast wave injury caused to the mice. They were exposed to 3 blast exposures. And then they looked at the Purkinje cells in the cerebellum. And what they found is, if you look here, you can see the presence of the red Purkinje cells here. After the mice were exposed to 3 blasts, 30 days later, they looked at that same area and found that there was a loss of the Purkinje cells throughout the cerebellum. So again, suggesting that repetitive blast exposure or the cerebellum might be particularly vulnerable to blast exposures. So building on that, we decided to use the functional MRI task, the MBAC task in the scanner, to look at how the working memory network in our veterans is affected. So for this study, we had a slightly smaller sample. We had 36 veterans with repeated mild TBI and 20 controls. Same presentation in terms of psychiatric symptoms. They were an average of 6 years post-injury, had an average of 11 and a half, or a median of 11 and a half blast exposures, and about half of the participants had 5 or more mild TBIs. So for those of you who aren't familiar, the NBAC is a working memory task that has different levels of difficulty. So on the easiest part of the task, the 1BAC, they are presented with these letters one at a time. So T, L, H, so on. And your task is to respond yes when the letter in front of you is the same as the letter that was presented just before it. So here, when the second Q is presented, you would say yes, because it's the same as the letter Q that was presented just before it. On the 2BAC task is a little bit harder. Here, you're asked to say yes if the current letter in front of you is the same as the letter that was presented to previously. So here, the example is B, T, L, T. When that second T happens, you would say yes, because the T was also present to before. And then the 3BAC is the same idea, but you're responding yes when the letter was presented 3 previously.
Do the subjects just see one letter at a time?
Yes,
So
and then it disappears. They just have to hold it in their mind what the letter was in the order of the letters. So one question was, could our participants do it? What was their accuracy like? The 3BAC task is pretty challenging to be able to hold that information in your mind and respond yes to it. And this is the overall performance in terms of their true positive. So how many times did they say yes when they should have said yes? So across the 1BAC, the 2BAC, and the 3BAC, the control groups did do a little bit better, but it was only significantly different on the 3BAC. But even within that, even though the controls did have a significantly better performance, the difference was there was 12 possible true positives. The average for the control group was around 10, and the average for the TBI group was around 8. So we think that means they're still engaged in the task, they're just not doing it quite as well. And overall accuracy for both groups, I think 85% or so was as low as it went. So, so what we did was we looked at the activation during these tasks. So this is the presentation of the results when you compare the activation of the control group and the mTBI group when they're doing the 3BAC task, so the hardest of the working memory tasks, compared to the 0BAC, which is a task that doesn't have a working memory component. They're just saying yes when an X is there. They don't have to remember anything else for that one. And so you can see in both of these groups, they are activating their working memory network like we would expect. So this is the working memory network we would expect to see, this frontal, parietal, cerebellar activation. And it's nicely present in both the controls and the mTBI group. The difference emerges when we look at the linear trend analysis. So this is comparing the activation of the brain as task difficulty increased. And there were 2 areas of difference that emerged between the deployed controls and our mTBI group when you look at this linear trend analysis. So the first one, here in blue, is that there's decreased activation in the cerebellum for the mTBI group. And this was true not just compared to the control group. So as the task difficulty increased, the control groups were activating the cerebellum more than the mTBI group. But it was also present that the mTBI group was not activating more of their working memory network as the task difficulty increased, like they should. The second pattern that we saw, or the second finding, was here, this aspect of the medial prefrontal cortex that was more activated or more present in the mTBI group than the control group. So this talks about that finding a little bit more. So again, these 3 areas up here highlight where we found the working memory network was. This is the area of the brain where we saw increased activation in the mild TBI group. So this is outside of the working memory network, but it's actually part of the default mode network. And the default mode network is an area of the brain, or it's a neural network that is active when the brain is at rest. And when you engage in a working memory task or other cognitive activities, the working memory or the default mode network is supposed to be suppressed while the working memory network comes online. And so we know that accurate suppression of the default mode network during a task is positively correlated with cognitive performance. So if you can suppress that default mode network while you're doing a working memory task, that's associated with better performance. However, failure to suppress that default mode network, like we're seeing in the mild TBI group, is associated with attentional lapses, not as good cognitive performance, and self-reported mind wandering. So again, in the primary differences here that we're seeing this failure to suppress the default mode network, and we're also seeing this pattern where the mTBI group has less activation in the cerebellum compared to our controls. And both of these findings can be associated with reduced working memory performance. So in summary, what we've found so far is that we have veterans with a history of repeated blast-related mild traumatic brain injury who are reporting a constellation of emotional, cognitive, and somatic difficulties for years post-injury. And as we saw, those difficulties seem to be remaining fairly consistent at a group level over time, even up to an average of 7 years post-injury. And consistent with the literature that's out there, neuropsychological performance is in the average range, even though they're reporting significant day-to-day cognitive difficulties. But when we looked at their performance on a working memory task in the scanner, we did see 2 alterations in the working memory network as task difficulty increased. And as I mentioned, both of those differences, the medial prefrontal and the cerebellar differences, could be associated with poor cognitive performance. So the other thing that I wanted to talk about was what the implications of these findings are. So not only is there a possible explanation for why they're reporting these day-to-day working memory problems, but this is also additional support for the idea that the cerebellum may be particularly vulnerable to blast-related traumatic brain injury. And we think this is lining up with some of the ideas that Schmahmann and his colleagues have proposed, that the role of the cerebellum really extends beyond motor functions and into the modulation of both cognition and emotional functioning. So given the findings that we have with working memory, we're interested to see if this might also be applicable to the high levels of irritability and other symptoms that these veterans are reporting for years post-injury. Okay. And so next steps. So there's lots of work that we're currently engaged in right now. As I mentioned, we want to look at things like the neural substrates of irritability and some of these other symptoms that veterans are experiencing. We're also continuing to recruit participants to really be able to try to understand some of these findings or do some of these analyses in veterans with just PTSD or just depression and compare that across our sample of veterans with mild traumatic brain injury. We are doing a longitudinal study, so I presented the data from about 21 of those participants, but Dr. Peskin just has funding to continue that longitudinal study out to continue following those veterans for several more years. And then ultimately, we also want to be able to compare the veterans with repeated blast-related traumatic brain injury to individuals who have repeated sports-related mild traumatic brain injury, and really try to understand the similarities and differences that are present. For me, I'm particularly interested in working memory, but across all these symptoms. And all of this work wouldn't be possible without the large number of collaborators that we have who are working on the traumatic brain injury research study. So we have collaborators at the VA and quite a few at the University of Washington as well. So do we do Questions? Yes.
Could you say anything about therapeutic approaches to some of these problems?
So yeah, so one of the studies that I've also been involved in is looking at a cognitive behavioral therapy intervention for the cognitive difficulties. And that study actually just wrapped up, and we found that doing a group-based cognitive rehab intervention was successful in reducing some of the day-to-day reported cognitive difficulties. And now that has been expanded or continued on in another study where we're actually combining an intervention for PTSD called behavioral activation with that cognitive rehab intervention to see if we can reduce symptoms of both PTSD and the cognitive difficulties at the same time. There's also some medication studies going on. I don't know if Dr. Peskin's here. She can talk about some of her studies.
We're the home of the crisis and
right.
So crisis and effective for post-traumatic stress disorder. We're doing 2 studies now using crisis for reducing drinking and heavy drinking days in active duty service members with alcohol abuse and dependence, and also using crisis for prophylaxis of post-concussive migraine, and a few more things we're working on.
So that's really interesting. Given that we see some diffuse axonal injury in some of these cases, I wonder about the white matter connections in the networks that have you or anybody in your group looked at, say, like diffuse and tensor imaging or white matter networks in this setting?
Yeah, so the Dr. Peskin's larger study actually has multiple neuroimaging modalities that we're looking at, including DTI as well as MPF, macromolecular proton fraction mapping with Vasily Yarnik is the person leading that up. You look like you're going to say something.
So we are finding, so we've done a few things. We've done just straightforward DTI for the usual measures. We've done some DTI tractography, which shows interesting findings in terms of using seed regions of the cerebellum. And our most sensitive structural technique so far is the NTBI, which gives you, it's an ionization transfer technique, which gives you the fraction of your hydrogen ions which are attached to big molecules versus small molecules, and it's been shown in both animal models and humans to be associated with myelin disintegrity when you have a reduction of your macromolecular proton fraction. And we're finding abnormalities in multiple brain areas, white matter, gray matter, and white gray matter border. So it seems to be the most sensitive structural technique we have so far.
Yeah.
So you said you could divide the TBI people into mild, moderate, and severe, and you're focusing on people with mild.
Mm-hmm.
So what if you chose the moderate cases? Are there too few of them, or wouldn't you expect that whatever you're finding would be more pronounced in the moderate cases if there really is this kind of dosage effect? Have you thought of expanding it to moderate, however you define moderate?
Yeah, that's a really good question. So the reason that we're focused, yeah. Oh, sure. Sorry. The question is, we are focusing on mild traumatic brain injury. So what about expanding that to moderate traumatic brain injury, and wouldn't we expect the effects to be more pronounced in that population? So the reason that we're focused on mild is the vast majority of injuries that are being sustained by the veterans are in the mild range of injury. And the way that the VA has set up their polytrauma centers is that the people with more severe injuries go to specific centers throughout the country. So our VA sees very few of the veterans with moderate to severe traumatic brain injury. The vast majority that we see, I know it's upwards, more than 90% of them are in the mild range.
Yeah, and I can make some comments on that too. I think they followed 25 veterans who have moderate to severe TBI themselves.
Yeah, okay,
Yeah,
there you go.
And also, it's really, and I think this is particularly the phenomenon of this war, that it is multiple injuries. You can only have multiple injuries if they are mild. If you have a moderate to severe TBI, you're medevaced out, the war is over. So you're not, your
So how would they differentiate the, I understand mild,
Yeah.
and I think I can imagine severe, pretty bad.
Right.
So what would moderate be, and couldn't you find 10 or 20 guys you could do a PET scan on with moderate? Or is it moderate worse than I think?
It's worse than, probably worse than you think.
Yeah.
So, just by, I'm not sure what the definitional.
Yeah. So for the traumatic brain injury, we follow the ACRM criteria for mild, moderate, and severe. And so it has to do with the length of time that someone is unconscious, the length of the post-traumatic amnesia, if it's available, what their Glasgow Coma Scale score was. So there are defined criteria that we would use to determine that. To find people who have blast-related mild TBI in the moderate range in our VA setting would be very challenging.
And even when, most of these injuries are alteration of consciousness, there's relatively few loss of consciousness. But even when there's loss of consciousness, it's almost always less than a minute.
But to have a moderate TBI, it has to be more than half an
it's
hour.
only for more than 30 minutes. So you can imagine that's a person who's getting major medical attention.
More than 30 minutes.
Mm-hmm. Exactly. Yeah.
So it's very nice work, and the population is challenging because there are lots of comorbidities.
Mm-hmm.
I sort of have two questions. The first is that a lot of the difficulties that you described are also what I would expect for patients who are having clinically significant depression.
Mm-hmm.
Impairment from depression. The second is, what do we know about the comparison between individuals who've remained in active service and those who are veterans with similar exposures? Are you finding the same profiles or different profiles?
Yeah, that's a good question. So, in terms of this type of research, we don't have any direct comparisons with the active duty personnel, but one of the limitations of the VA research is that we are limited to veterans who are coming to us for care. So we don't have access to the veterans who maybe had one or more blast exposures but are doing well, and aren't coming in for care. So that is a question I've always had is, who are the people who are doing well after these exposures and how do they differ from the veterans that we're seeing? Your other question was about the depression. You're right. There's lots of overlap between all of these symptoms, and none of these symptoms are specific to or diagnostic of TBI, and that's part of the challenge. In some ways, I feel like things have evolved. There used to be a focus on trying to parse it out. How much of these symptoms were depression? How much were PTSD? How much is traumatic brain injury? And now we've kind of realized this is how they're presenting, and this is what they're dealing with on a day-to-day basis. And so we're just trying to understand, what is their symptoms, what is driving those, and can we figure out interventions that would be helpful for treating the symptoms that they're experiencing. So obviously, if someone is depressed, we want to get them into treatment for the depression and see if that changes any of these other symptoms as well. But we also know that a lot of these symptoms remain chronic even if individuals are in treatment. So we're trying to figure out ways to help in that situation. Yeah.
There are two questions from the
Oh, okay. Let's see. So the first question is, what is your opinion on the potential for biomarkers in the diagnosis of TBI? So that is outside of my field, but Dr. Peskin again can answer that.
I can so answer that question because I'm preparing my slides to go present for the kickoff meeting for the Boston University U01 on the clinical diagnosis of chronic traumatic encephalopathy. And so I've carefully reviewed all the data on biomarkers. So there's a handful of biomarkers that have been well replicated in moderate to severe and acute TBI. And I probably can't remember all of them, but they're S100 beta, neurospecific enolase, GFAP, there's been a couple more.
Is this CSF?
This is blood. Right. And with respect to CSF, they're really, expected blood, first of all. Now there have been a couple reports, now that we have this Quantrix Simoa technology that can, single molecule array, that there have been a couple reports of plasma tau being elevated. very complicated by other potential sources of plasma tau, such as muscle tau. As of now, the commercially available tau, antibody-based assays do not distinguish between brain-derived and muscle-derived tau. And now we have even newer technology measuring CNS-derived exosomal tau in blood, but we're not there yet with TBI. With respect to CSF biomarkers, there's really very little. We have found we're looking at the neurodegenerative biomarkers, A-beta-42, tau, phosphorylated tau. We have not found a difference in absolute values, but we have found an increase in the ratio of phosphorylated to total tau, about 20% in our TBI veterans. And this is going to be obviously and we've also found an elevation, and this is not published, so don't be going to tell everybody. We've also found an elevation in both interleukin 6 and interleukin 7. Interleukin 6, a relatively straightforward inflammatory biomarker, and interleukin 7, a little more mysterious. It's expressed, these receptors are expressed by astroglia, but we don't know too much about it. So that's what we know so
But a
far.
biomarker for mild TBI, I mean, there's the clinical diagnosis, I mean, the screening instrument just if you're stunned, dazed, brief loss of consciousness,
Right.
you
That's
have a mild TBI.
Mhm.
I mean, you're not going to
That's
prove
the
it.
definition.
That's
Right,
the
the
definition.
definition,
So you're
right.
not going to prove or disprove
But
mild
we're talking
TBI
about-
with a biomarker.
But we're talking about long-term changes.
Right.
We're talking now 5, 7 years out, having changes in CSF
So it-
biomarkers many years
It's
out.
correlated with chronic symptoms or something.
That would distinguish it from a different chronic progressive degenerative process that was
Or PTSD or depression.
So some of the football players with a direct football injury and PTSD kinds of symptoms, cognitive decline kinds of symptoms, have come to brain autopsy,
Mhm.
which you see in the media every once in a while.
Right.
Have any of these kinds of cases come to autopsy?
Oh, the veterans?
Yeah.
There have been, yeah. So Ann McKee out in Boston has done some work that has looked at brains of a handful of veterans.
Anything? See anything?
And do you want to
So
comment?
there's
And
been
Elaine's also
reported
doing
in-
that.
So really 3 sources. So in the literature have reported already there have been 5 cases in Iraq veterans. 1 by Bennett O'Malley and 4 by Ann McKee. Of course there's huge accession bias in this, but all 5 cases have the typical neuropathologic features of chronic traumatic encephalopathy. I believe Dan Pearl has a paper that came out today, I believe is no longer available. And he showed us some slightly different changes. I don't want to say anything in case.
And do we,
About it.
is there any confidence that those cases you just referred to did not have the other kind of head injury?
No, it's very common for veterans who have blast head trauma to also have impact head trauma.
Exactly.
Many of them are former high school athletes.
Right.
And then the sort of combination, your striker vehicle runs over, an IED, but then you whack your head on the
So,
side of the
so
vehicle.
they're not pure blast
No.
TBI by any.
Correct, yeah.
And was any comment made about the cerebellum in those cases?
I don't recall that it
No, it wasn't.
They probably weren't thinking about it.
No, they didn't talk
Are you
about
gonna
cerebellum.
Thank God, I should have had you answer this. I didn't see you behind Tom's head.
So not yet. So we'll see with this new report what the results have to show.
So I think that
So
Dr.
it's
Rash had
happening?
a question too.
I haven't seen.
Yeah.
So I had a question about your fMRI
Okay.
paradigm. So do you think, what about the possible interaction between affective and cognitive factors in that performance? So it's a frustrating task, the feedback is really hard to do.
Yeah.
You've got some emotional discontrol, maybe they find that more frustrating. And I think there's some evidence that there's a U-shaped relationship in terms of default mode reactivation and adrenergic count.
Mm.
So I'm kind of wondering, do you think that's a possible, have you
Yeah.
looked at how they experience that
We
compared to the control?
definitely, we have comments, observations of how they're doing in the scanner. And one of the things we will be looking at is if we control for PTSD symptoms, preliminarily, what we wanted to look at was just making sure that they didn't get so frustrated they stopped doing the task, and that's why we were looking at the accuracy and try as a kind of proxy for their engagement in the task. You know, I definitely, from the handful of people that I have trained to do the task in the scanner, I think frustration definitely is a component of it, more so I saw in the TBI sample than in the deployed control sample. So I think that's definitely something we have to look at.
Prefrontal areas connected with emotional
Right,
processing.
absolutely.
So it might activate in that situation.
Yeah, yeah, that's a very good point.
Dr. Gospi has a question.
Oh, okay. Okay, the other question is, are there any differences between younger veterans age 18 to 21 who were injured versus older veterans in their 40s and 50s when they had their injuries? We haven't looked at that yet, but that is something we want to look at in the future. And we've actually extended the age limit of our enrollment up to, our oldest veteran is now 61. So we can look at age of injury and have quite a spread in terms of looking at the age impact. Yeah.
I was wondering, and you may have said so, but were these populations matched in terms of military occupation, i.e. were soldiers who were exposed to a higher level of stress potentially inducing hypervigilance, you know, where's that controlled for? Because I know with some of the veterans that I've spoken to, they talk about their memory issues being linked to the hypervigilant state, whether or not they actually experienced any organic trauma.
Yeah, I mean, you can absolutely have cognitive difficulties associated with PTSD alone for that very reason you described. So you're attending to other things in your environment instead of what's going on in the moment. We often talk about PTSD being a disorder of the present for that reason. They're either thinking about what happened in the past or what might happen in the future. So, you know, that is absolutely something that's definitely a contributing factor. One of the issues that we have is that it's almost impossible to match for their position in the military because the folks with the highest number of blast exposures were doing things like EOD. And I don't think which is the people who go out and find the bombs and explode those. And so finding a control who had no blast exposures, who had that type of military role, we just haven't been able to do that. And even being able to look at veterans who were deployed without TBI, who have PTSD, that's been hard for us to recruit into our study. So trying to parse these things out, just in terms of the population we've been able to enroll, has been challenging. Yeah.
Not 100%. I can answer that question actually. So roughly, so the primary military occupational specialties, MOSs, in our TBI group are you know, explosive ordnance disposal, infantry combat engineers, and MPs. Our control group were about 50-50 administrative and combat veterans. So, but you know, the problem that Katie's talking about is you can't find that many combat veterans who haven't had these exposures. And when and we've done 2 studies where we've recruited from both sides of the equation. So at the VA, where we're doing TBI studies, we're recruiting people with TBI. Over 75% of the time they have PTSD as well. In our active duty soldier study for PTSD, when we recruited, we had the same overlap. So recruiting for, you know, combat trauma, you know, PTSD, military PTSD, we found 75% of those also have that. So either direction you recruit from is the same.
Yeah.
Do you find other evidence of cerebellar dysfunction in these veterans?
In terms of motor symptoms, or
speech?
not prominent, for sure.
Components of the cerebellar cognitive affective disorder.
I would say what I've seen clinically is more on the cognitive and affective side as opposed to the motor side. You do the UPDRS as part of the evaluation.
And you know, they get very low scores, but the only thing they get a score at all on is, you know, comparative numbers.
Yeah.
And then they do have higher scores on the you know, balance, coordination, you know, sort of the sensory motor integration cluster of those NSI symptoms. And then when we do cerebellar testing in the mice, you know, we call the mice who've had 3 or more blasts unsafe at any speed on the road ride.
One more question.
Do we know why the control population had above average MIST scores?
So that's a good question. That's a test that we don't tend to use clinically. It's a test that we added in because the standard clinical measures of retrospective memory is they just don't pick up any group differences. So I think that it's just a task that they can do. I don't have any other better than the average. Yeah. It's not the norms for it, frankly, aren't the best though. So it could have something to do with that. But yeah.
Let me say something about your control population.
Sure.
And I'm a former Army neurologist who was head of neurology and psychiatry at a large evac hospital in the United States during the Vietnam War. The blast injuries were not an issue. And I won't even address that. You've done that brilliantly. But we had an awful lot of people with what is now called PTSD. We called it something else. Same issue, but we were not studying this. We were just taking care of the patients and distributing them in a large community. A major discriminating factor was whether they had been in combat or not. And that's easy enough to find out.
Mm-hmm.
You don't have to go through their MOS numbers. You just ask them whether they were in combat. We saw relatively little PTSD from the non-combat troops, even though they were in some degree of danger, more so in the Vietnam War because of the characteristics of the fighting there. But those who were in actual combat had a far higher percentage of PTSD and some other neuropsychological consequences without head injuries. I'm talking about the head injury group. And you might find it interesting if you split your control group into those who were in combat and were not in combat, because I think you would see that they are not identical. The two halves of that control group are not identical.
That's a really
good point.
That
might have some bearing on the way you draw conclusions about the head injury.
Yeah, that's very interesting. We've actually started recruiting a group of individuals who were in the military during OIF, OEF, but never deployed to have an additional comparison. But you're saying within the deployed control group, looking at those who were in combat versus those who weren't. So that would be, yeah, that's a good idea.
But, to draw from my experience, it's not identical. We saw people with PTSD fairly frequently who were not in combat. And I think that's different than the ones who were stateside. We saw very little of that, at least that were sent to us. We were the only game in town, so to speak. But I think dividing your control group for combat and non-combat for people who were in country might be useful, and it isn't a huge amount of work to do.
Yeah, we have that information. That's a great idea.
And we get a combat experiences scale as well, so we actually have a quantified measure of combat exposure.
Right. Oh, that would all add to it.
Yeah.
Well, thanks, Katie, for a great
Thank you.
talk.